What is the situation in Ireland currently compared to, I know you work in England as well?
We actually don't even have pre-hospital emergency medicine. So there's no doctors that are paid in the pre-hospital in Ireland to provide this. So somebody has a road traffic collision today and they need to have an emergency intervention on scene. You do not get it in Ireland, but you will get it in the UK. Why? Because
there is a little bit of a disparity between the ladies' football and the men's football in terms of even the care that the athletes get. Is that
yes,
right?
Yeah. So I
Do tell, Lisa, do tell. Dr. Lisa Cunningham.
How are you? How's things?
I finally got you in the hot seat.
Well, it's finally get me out of Mayo to get up.
I know.
And
you came down especially, which is great.
Yeah, absolutely. I said I'd book a nice little place, come up, and it's not too often now that Mayo gets to come up to Dublin to the big smoke. And obviously Mayo didn't do too well this year in the football, but I'm coming back up again on Sunday anyways for the ladies' finals.
Okay, so. Wonderful. And we'll get into all of that and your love of the game, etc. But first of all, and primarily why I asked you on here is because you have a bit of a passion project at the minute.
Yes.
And I want you to explain what it is and why you are doing this.
Okay, so the project which I'm involved with is trying to get an increase in critical care to patients in the pre-hospital in Ireland. And this has come about from my love of the pre-hospital. So I've been doing pre-hospital medicine for probably the last 4 or 5 years, but actually I've been involved in the Order of Malta, and I know that we're going to come to that later on. But that is one of the largest pre-hospital voluntary groups. I've been involved in that for 25 years. So like we would be on duty at rugby matches, football matches, the festivals. So you get to see people who need first aid or even a cardiac arrest. So I had a little bit of a grow and a passion for that pre-hospital aspect, but I didn't know exactly what I wanted.
Explain what pre-hospital is first.
So it's any care that's given to a patient prior to coming to the hospital, but at an emergency need. So it's not a primary care, as in like it's not going to see your GP with your sore throat. This is when somebody falls off a bike, falls off the monkey bars, might have a medical emergency, like maybe they have a very low blood sugars with diabetes, or they have a seizure. So something that's sudden for somebody in an acute setting. So they're out at a festival or they're at home and have a heart attack. So any care that's given to somebody in the pre-hospital in that environment in an acute setting.
So like a road traffic accident would be considered that?
Yeah, so road traffic collision is, that will be absolutely part of it. So anything that encompasses trauma that's acute, so it's just happened to them, that you need to get care to them there.
Okay. And what is the situation in Ireland currently compared to, I know you work in England as well. Mm-hmm. So if you compare the two, and we then will understand why you want to bring this to Ireland.
At the end of my emergency medicine training, you're allowed to do your fellowship. So I went over to the UK to do a fellowship in pre-hospital emergency medicine, which is a subspecialty of emergency medicine. So that's where I really got to see the differences between the two systems. And what it is if I could describe it in this way. So somebody has a road traffic collision today and they need to have an emergency intervention on scene, which will be something like either blood transfusion or somebody that needs to be put into a medical induced coma. That is a standard of care that we would normally do for people that has this certain injury. You do not get it in Ireland, but you will get it in the UK. And even so, you'll get it 3 miles across the border in Northern Ireland, because they have this level of interventions in Northern Ireland. Why? Because we don't have that level of care, of critical care in Ireland available to the patients yet. We have a fantastic National Ambulance Service and we have fantastic pre-hospital personnel, paramedics, EMTs and advanced paramedics.
What's an EMT?
But the emergency medicine technician.
Okay.
So these crew have a skill set, but the skill set that really is needed for these patients is far beyond the scope that's there. And I suppose, is it because we've lagged behind a little bit? Trauma care has really come on in the last 10, 15 years. Like we now know, blood transfusions in the pre-hospital has been done probably for the last 15 years in the UK. And we now have loads of evidence to show actually that these interventions are needed in the pre-hospital. But we haven't had the upskill yet in Ireland to allow that to happen. And likewise, we actually don't even have pre-hospital emergency medicine. So there's no doctors that are paid in the pre-hospital in Ireland to provide this. We have voluntary doctors, which I'm part of a group that does this, but we don't have blood, or there's 1 or 2 consultants that would have blood, but you don't have that same equity of care across Ireland. So I'm very passionate about Mayo because we obviously have a very rural aspect of it. And I remember a colleague of mine saying to me before that, Lisa, we can't change the geography of Ireland just so that a trauma centre could be built in Mayo. I I don't want that. But what I do want is equity of access, so that when my child falls off the tree, bags his head and needs to go into medical induced coma and needs to get access to the major trauma centre, that he has the exact same access availability as somebody who has 5 minutes from Beaumont or from Temple Street. So, you know, I get to see the Northern Lights from my front door. I get to have really nice... Somebody said to me before, this is the sacrifice that you have for clean air and cheap mortgages living down the country. And that was a very senior stakeholder in the health service that said this to me. And I do not believe that. That is absolute BS. Like, I just want everybody to move down to Mayo.
So do the crew in the UK, do they have a doctor on site that can provide this blood and provide this medical induced coma?
Yeah.
So it's because advanced paramedics and those medical technicians, they can't provide that. It's not within their training.
They have a scope of practice. So yeah, it's not within their training for it. There's a ceiling to their level and ability to be able to do it. In the UK, so the UK is made up of a few different countries. So in England where I work, it's all charity air ambulances, which are HEMS, Helicopter Emergency Medical Service. And the majority of them, I think bar one, but they're actually going to be changing to this, they are all doctor, paramedic inclusive, meaning that the team that you get at a road traffic collision, at a site for trauma or medical emergency, is a multidisciplinary team, meaning that you have a skill set from a consultant in, and it could be emergency medicine, anesthesiology. We actually even have an orthopaedic consultant, but he has actually got a skill set of all the other specialties. So he actually is able to do the emergency work of an anesthesiologist, emergency medicine consultant. So you have the consultant skill set and you have the critical care paramedic skill set. So the two of us combine to give that skill to the patient. That's a charity funded in England. In Scotland, it's a mixture of charity and NHS funded. In Wales, it's charity but mainly NHS funded. And in Northern Ireland, it is charity but NHS funded as well. So people sometimes are quick to say, oh, well, that's a charity model and we don't have that in Ireland. No, but we actually have a really good opportunity. We are a small country and we have a fantastic opportunity to, if the HSC or if whatever stakeholder wants to take this on, to say, right, we can do this and it's public funded, which I believe that it should be public funded. We have a great opportunity to do it.
Okay. So tell me the difference in what happens, someone in England versus someone in Ireland today in a road traffic collision down the country.
Yeah.
Or far from a trauma centre.
Yeah, so even where I work now, I mean, we span 2 counties, and to get from one side of the county to get to the major trauma centre is 2 hours by road. So
where do you work?
Links and Notts Air Ambulance. So
okay.
Lincolnshire, Nottinghamshire. And say, for example, there's a little town at the very, very, very east coast of England. To get from there to the major trauma centre is 2 hours by road. So it would be similar to having like the geography here as well. So when a road traffic collision or an accident happens, we will get a direct call to the airbase, because there are a category of calls that will trigger an immediate response from an advanced critical team that needs to go. So rollover road traffic collisions. If somebody rings up 999 and said there's a rollover road traffic collision or the car is on its bonnet or whatever, that would be an automatic dispatch for us. Now, if the patient then 5 minutes later gets out of the car and everything is absolutely fine, you know, then that's fine. We could get stood down. But we are automatically dispatched. Stabbings, we would get dispatched automatically too as well. Because
stabbings.
It's time. Yeah, stabbings or, you know, farmyard accidents.
Is there a lot of stabbings?
Yeah, I think I was very naive. So when I done my fellowship, it was in Essex and Hearts, which is... Essex, don't be so naughty. I loved it over there. But my gosh, my eyes were opened to the amount of stabbings. And we would routinely be in London then. So just, there's a border. It's kind of like the M50 here. I think it's the M25 over there. So routinely we'd be at areas that were well known for stabbings. I was very shocked at the amount of stabbings. So stab culture and gun culture over there in certain areas were very, very common. So we get an automatic dispatch to go to these. And we would then mobilise. By the time we get to the aircraft and lift, you're talking probably about 4 minutes. So you're always ready to go. So no matter what you're doing, you literally just go straight to the aircraft. There's one of the pilots will take a call and will take the details, so the grid reference, etc. We might just get rollover RTC, 2 patients, 1 trapped, not breathing, or something. It would be very simple like that. And I don't want to know any other details while we're en route, because it will impact in your bandwidth. If you found out that it was a paediatric patient, you might start getting really nervous about it, and you'd have time to get nervous about it. Whereas if you found it on scene, you just go, I have to deal with it, that's it. So we take all of this kind of while we're going, that this is the line. We just have a job to do and go. So normally we will arrive from where our airbase is to anywhere around the 2 counties, normally within 12 minutes or so, 10 to 12 minutes. It would be very unusual that we'd have to go further afield for that. So you're talking by the time that somebody has a rollover, a road traffic collision, that might have a spleen that's bleeding or an injury to their chest that they need breathing support with, we're there probably within about 12, 15 minutes. And you're getting advanced critical care. Now, might be a ground response that's already there as well. So a ground crew in the UK, so a paramedic, they might give us updates from scene, etc. And we all work together. It's a really nice collaborative way that we all work together. The way I say it is we have a skill set just to offer to a patient. It's not in any way that, oh, here we are, there's no one like us. I have a skill set. This is what the patient needs. The patient may need to be extricated from the car. I haven't got a clue how to do that in general, but there's a specialist paramedic that knows how to do that, so that's their job. So everybody works together to get this patient out. It is similar in Ireland that we have something like that, but it's just the advanced critical care of when that patient comes out, we see, oh God, they're big sick. They look like they're bleeding. We have all the parameters that shows that they're bleeding. They need blood. The difference is now that we can't give that blood in Ireland. Like if you're in Belmullet, which is probably about an hour and 20 away from my hospital at the best of times.
Where are you? Which hospital are you in?
Mayo University Hospital in Castlebar. But even for geography-wise, remember this patient in the UK is 2 hours away from a major trauma centre. So how do we get this patient in Belmullet to the locals hospital to get the blood? Because the blood will only be delivered once they cross the threshold of the emergency department, because there's no availability of it. There's no availability of, if the patient needs to go into a medical induced coma, to help with the breathing that they might have gotten from the steering wheel that was really impacted on them, and they have a lot of rib fractures. So now they have an hour and 20 of an advanced paramedic who are normally, even in Mayo, we don't even have a 24-hour rota for advanced paramedics. So that's the highest skill set that you can have in the pre-hospital. They're doing their best to the best of their ability with their skills that they have, but knowing that actually there's an extra piece of that skill and care that the patient needs, but they can't deliver because it's not within their scope of practice.
And this is in the helicopter service in Ireland?
Even in the helicopter. Yeah, the helicopter service in Ireland has an advanced paramedic on board, sometimes two. And even the dynamic of where they're based, etc., because we have the one in Athlone that's military, so it's actually part of the Air Corps. So if they are, away doing military aspect, so there was, massive drug seizure that's down off the coast or something like that, their helicopters may not be as available. They might have a lot of flying restrictions. We have the Search and Rescue Coast Guard as well, which are based around the different areas like Sligo or Shannon, Waterford, etc. So they may very well come as well. They should have an advanced paramedic on board. Sometimes they will have paramedics on board. And then we have the newer helicopters that are based out in Cork. They are a smaller helicopter. They're actually very nifty. They're like a little bumblebee. They're what we would use in the UK. So it's like quick to lift, quick to go. You can land them anywhere really. Whereas the other two would have very much limitations as to where they could land, even easier access to the patient, etc., loading the patients, etc. So even down to that nitty gritty aspect of it, there's a huge variation on such a small island.
So in Belmullet, if someone was in an RTA, road traffic accident,
so we do say road traffic collisions.
Road traffic collision.
Yeah, collisions.
Oh,
yeah.
right,
so
sorry.
There's a difference, and that changed a while. I think it's just more that it encompasses that they can be accidents, but there's actually other factors that would play into it as well.
Okay, it's important to get the language right.
Yeah.
So that happens in Belmullet, and an ambulance crew by road or by helicopter goes?
But it depends. If there's availability for the helicopter, they may get dispatched.
Okay.
And even with the dispatching system, so when somebody rings 999, in the UK, we would have normally clinicians on the desk that will be looking at these calls and monitoring them. So you would have normally a critical care paramedic that's scanning all these calls on the CAD. So this is a system that they use. I love going into it, just have a look and see. You can see all the calls that are going, and they might just go, okay, there's a road traffic collision. I'm just going to click into this. They can actually listen to the call that the call taker has taken, and they can hear certain aspects, and they'll say, okay, no, this actually needs to go for helimed, for the helicopter, so then they will dispatch. In Ireland, that doesn't tend to happen. We don't tend to have a clinician. So you would have somebody who is trained as a call taker, and they will try and trigger the response of the helicopter, but sometimes they may not be able to get it, or the helicopter might be unavailable, etc. The helicopter in Ireland is used, and National Ambulance Service have said this, is to go and get the patient and bring them to the definitive care quickly. Whereas in the UK, we very much go, the helicopter is used to bring the care to the patient to stabilise them, and then bring them to the definitive care.
And that's the major difference.
Big
and
difference.
Obviously, as with everything, early intervention can be the difference between life and death. Is that right?
And this is literally sláinte care, Laura. So this is the right treatment for the right patient at the right time. And we've done this really well with, so for heart attacks. So people who have major heart attacks and have to go to the PPCI centre, which is normally the centre where you go get your stents. So we only have one in the west of Ireland, Galway. So if you have a heart attack up in Letterkenny, you have to get from Letterkenny down to Galway, normally within 90 minutes, to try and get your stents in. So the helicopter service is used for that. And we like the west of Ireland, it's fantastic for STEMIs, which is the heart attack, ST elevation in MIs. We do a very good service in the west of Ireland to try and get them down to PPCI centre pretty quickly. And the helicopter is used for that, to go retrieve them and bring them straight to the definitive centre. And that's exactly what needs to happen. I can't do stents at the side of the road. Whereas we're talking about with traumas, or even if somebody went into a cardiac arrest, we know that when somebody goes into a cardiac arrest, if we can get them out of that cardiac arrest, it's great. You can sit back and go, geez, that's brilliant. They have a whole trajectory to go afterwards. We have a whole aspect of their care, because if they are able to come back, they've now been deprived of oxygen for a few minutes. So they come back normally, in general, they come back with this agitated kind of like pulling at everything. So they need to be either sedated or maintained. They don't protect their airway afterwards. So you have a whole course afterwards when somebody comes back after a cardiac arrest. That is the advanced critical care that we will do. No problem once they cross the threshold of the emergency department. But if you're out running in Belmullet and have a cardiac arrest, you know, that advanced care in a situation where you come back from a cardiac arrest, it's just a little bit, it's harder to do because we can't maintain their airway. We can't put an intubation into them, which is the medical induced coma, which is one of the parts that we should be doing if they come back with that agitated kind of
and you
lack of oxygen.
You could do that if there was a doctor that was specially trained in this. And there's no way they can train up the paramedics to do this, is there?
They've tried to do this, and there has been a few that have are doing critical care paramedicine, but you will still need, even just to develop that out for the whole of Ireland, you're talking about 4 or 5 years.
Yeah.
Whereas now we're like, well, we're here. There's definitely a few of us that are trained in this anyways in Ireland. At this moment in time, there would probably be 3 of us that are current, meaning that we work in the UK in a current system of a helicopter emergency medical system. And we're current as in that we are doing pre-hospital intubations, you know, in a governed system. And every Thursday we will go through our cases, and I will get very much critiqued about my case. Lisa, why did you do this? What did you, in a very good way, to really make you go, do you think you should give 1 milligram more of that medication, etc. And these are all by colleagues of anesthesiology, you know, general surgeons even, like, and we'd all collectively try and improve that care for that patient. So in Ireland, when we're doing it at a voluntary way, we try our best to kind of come together and say, you know, what did you use? Can we improve this? But there's no standardised or governance approach to it in Ireland. And we very much can do this. It would be like if you had a consultant, respiratory consultant, and, you know, they're based in the hospital, but they also do outpatients in, you know, a place that's far away. So like in Castlebar, to get a respiratory consultant in the outpatients, you can go there, or they can actually do outpatients in Belmullet or outpatients in Ballina. So it's kind of like an outreach part. So you're still taking me as a consultant in emergency medicine, working in the hospital, but actually give me 12 hours in my week or 12 hours every 2 weeks to go and do my skill set here and go to the patient. So we all work under HSC, including the National Ambulance Service. So you're just bringing me now to the patient that needs it most, regardless of getting them to me to across the threshold.
And so you say there's 3 doctors that are currently skilled enough to do this in Ireland?
That we're qualified. We've done our fellowships, we've done our training with it over in the UK, yeah. There are others that are voluntary. And again, I've done voluntary for the last 25 years in pre-hospital in Ireland, but I would never say, you know, that that's what has gotten me to the stage of being able to be comfortable to open up somebody's chest at the side of the road, because that's part of what we would do as well for, say, stabbings in the chest, to do a cardiac surgery, emergency cardiac surgery at the side of the road.
Have you done that in England?
Yes. Yeah. That
But
would be...
But you, even in your voluntary capacity, you couldn't do that here?
Absolutely not.
In your voluntary capacity, can you intubate here and can you administer the drugs and everything here? Or is there still a grey area?
It's a grey area, very grey area for carrying medications for that.
Okay.
And it's not a proper governed system here, that I would be very afraid about that as a pharmacist. That's my answer. But no, that as you, a pharmacist, that's your answer.
That's why I was asking. Like carrying CDs.
No, absolutely not. There are some that will do it. And obviously we have to do it in a very special way with the 2 pouches locked away and all that sort of stuff.
Sorry, CDs are controlled drugs that are governed by, there's huge regulations about it. They're highly addictive, but they're great for what they do. They provide serious pain relief, etc. They're like the morphine and things like that. Just
and there are doctors that in the voluntary capacity that would do it. And we are very tightly regulated in that way because most of the doctors are associated with charities. And it's our medical licence at the end of the day anyways. You don't want to be messing about with that. But they are very much, I will absolutely say that is very much tightly regulated about the double pouches. Always go with the doctor everywhere. I don't do it because I just don't feel I am happy to have that as a system. I feel this should be a public system. It should be properly governed as in with a higher structure for it. And also, I just feel like it needs to be in a proper system for me.
Okay. And can you give me any examples, obviously, of, I suppose, over the last number of years, examples of accidents, collisions or trauma happening people that resulted in serious injury or even death that could have potentially been prevented by this service being here?
Yeah, and I know this is really uncomfortable to say this because people are saying, oh God, you can't really say this out. But there is very well documented evidence that physician inclusive teams in the pre-hospital will reduce mortality and morbidity by up to 37%. Like that's very well evidence based. Now they'll say, well, is that just because you have a doctor before your name? You have to have a properly trained doctor that administers this advanced critical care. So by me saying this, I am not in any way, talking out of turn. This is very well evidenced in other countries. The UK, Australia, America, Scandinavia have a fantastic system with this. There's definitely been a few that I have noticed, and I've actually highlighted it through the proper channels within the HSC, like in the reporting risk system that we have. And I think recently was really happened to drive this on. There's been definitely a few cases between road traffic collisions. Ireland is so small. I get to hear a lot of what happens in the pre-hospital. I have a lot of colleagues that are paramedics, EMTs and APs that will reach out to me, and it's almost like I can feel that they're morally injured because they know what we're trying to do is in the group that we're trying to do, what I'm trying to do, and the skill set that would be beneficial for these patients. So there may be a kid that has fallen off of monkey bars or something like that, had a head injury that needed to be in a medical induced coma for the swelling that was happening on the brain, and just knowing that skill set is not available to do that at the side of the monkey bars. Instead, the patient has to be transported an hour away and actually deteriorates en route, etc. That sort of stuff is absolutely happening that we know. I'm working very closely with actually the Chief State Pathologist, Dr. Linda Mulligan. She is amazing. She's a fantastic woman because we need to see where this is happening and try and improve it. So what we can do is we're looking at pre-hospital deaths, and she's actually already started this as a study retrospectively. And what she will do is give us these pre-hospital deaths. When I say us, this is a multidisciplinary group. So from all the different professions, I will say, right, this patient, died of blood loss from a spleen rupture. Would you have made any intervention differently with your experience in the pre-hospital? And you may say, yes, this patient would have had blood. And then that's how we know, like, okay, there's potential of survivability of these patients that actually, if we had blood, if we had an airway secured, which is the intubation into the patient's lungs, not just a normal kind of basic airway, then the patient would not have low oxygen levels, would not have had swelling in their brain because of that low oxygen. So there's a whole trajectory that happens afterwards. So to have pathology reports, which they done in England in the early 1990s, I think it was, actually changed their trauma system. So they changed their trauma system to say, right, patients that are dying, survivability of X, Y, and Z, we need to actually make sure that they get to the proper centre on time, and that they have the skill set of, intubations available to them, etc. And even more so in 2008, they'd done this over the UK. They had this NECPOD, the National Confidential Inquiry into Patient Death. It would kind of be like NOCA, the National Office of Clinical Audit here, where we look at things, we'll say, what can we do better? So they have this in the UK. In 2008, it came out and they looked at trauma in the pre-hospital. And they actually were able to formalise and say, we need more of these critical care skills available to patients, because patients were getting to hospitals with really bad airways, they were getting with blood loss, etc. And from 2008 onwards, it actually helped to change the pre-hospital aspect in care in the UK. And these are all things that we are very well drilled and versed in for our fellowship, because this is our specialty. It's why it was created. This is the evidence that happened, and this is the change. And from the trauma system in the UK, we can now see that there's been a huge amount of survivability because of aspects that have been targeted.
Okay. And can I ask you about the numbers? Because when is a death considered a pre-hospital death or a hospital death? If someone is brought in a very bad way, in a very, deteriorated state into the hospital and they die in the hospital, is that a pre-hospital death
that's
or
a hospital death? And
so are the figures even correct?
No, they're not. And you're right
Okay.
about that, because the CSO, and this is something that we had a very fantastic meet with Minister Chambers when he was in his capacity of Road Safety Authority, or Road Safety Minister, not the RSA, and other kind of stakeholders. And we presented this. We said, this is all the evidence that we've gathered over 2 years, by the way, Laura. And we painstakingly tried to extrapolate this out, because some of the data is not very forthcoming with this. So trying to say, right, if somebody dies when they cross the threshold of the emergency department, then it is registered under our major trauma audit. So if they come in from a trauma, so we capture that as the figure. If somebody dies in my emergency department from blood loss and they did not get blood, I will be hauled in front of a coroner's inquest, rightly so, further down the road, to say, why didn't you give blood quick enough? Where was the blood? How come you didn't activate the massive transfusion protocol? And I would be grilled, but in a critique way, to say, what can we do better for this patient so it won't happen again? If you die in the pre-hospital, so before you cross the threshold, it is very rare that it will be in a coroner's inquest. It will be very rare that it will get to that stage. They might have a post-mortem that would say he died from blood loss or she died from blood loss, and then that would be it. Okay, next one. Nothing would then come back. So this is what I'm working with Dr. Mulligan for, to say, can we use that then of those post-mortems to say, can we improve this? Because if it happens crossing the threshold of the emergency department, there's a whole rigour of events that happens afterwards, and rightly so. But if it happens before the pre-hospital, we really don't have as much of that. And they're not registered as in our major trauma audit. Absolutely not. If you die from a road traffic collision in the pre-hospital, you're not in our major trauma audit figures, because you haven't crossed our threshold. So therefore, we don't know technically what injuries you have, etc., because we haven't captured it in our hospital data.
But on the flip side of that, if someone comes through the doors after suffering a huge amount of blood loss in a RTC, and you don't have the time, you can't give them the blood on time, or they die within a few minutes of crossing your threshold, is that death considered a death in the hospital death? Okay, so they don't even have the figures correct, the amount of people that are actually dying from these traumas.
Not really, no.
But as a result of them not getting the correct care, because they're not actually bringing the figures together.
No.
Oh, Jesus.
It's kind of like two separate things. Yeah. So I'm frustrated over this. I really am.
Listening to you. And that's why I asked you about the figures, because I know that there is this disparity across the board in all kinds of areas.
Yeah.
Okay.
And it frustrates me so much. And I say that it's morally injuring for myself, but also for a lot of my colleagues around the country, be it in medicine or in the pre-hospital world, because we know that we can do better. If we can just think outside the box, if we can actually just, instead of saying that, we can't change the geography of Ireland, Lisa, instead of maybe we could just rejig things and actually say, they need this care. Can we not bring the care to them rather than having to wait for them to come an hour and 20 across the way? And there's a few barriers that we're jumping through to try and get to that side. But I go over back to the UK. I know what I can do. I know what all the system can do in the UK. I know what that multidisciplinary team can do. And then I come back to Ireland and I'm full of optimism that we can do this in Ireland. I really am. I genuinely am. And I do think that we're getting there. And we're not the first group, by the way, to have started this. This was done again in 2018, I think it is. A group of consultants wrote an open letter to the government, the Irish government, imploring them to actually put doctors on the helicopters when it was being rejigged and rechanged. And this was an international group. Some Irish that have gone abroad and gone to Australia, etc. Some really big names in our pre-hospital world. and nothing was ever done about it. So we're not the first one to be ringing this bell by any means. I think we're probably the one that has kept kicking and gnawing away at it. And I think because I work in Ireland, live in Ireland, and I'm probably one of the only members of the current group that we have, but I see it, and I know we can do better. And I think, I'm only seeing it from one hospital.
Yeah, and you see it because you are living down the country and you see what is happening. Can I ask you what the blocks are? And
I would love to know what the blocks are. I think it's change. I think it's the fear of change.
What, you mean people in the HSE don't want change? That's a surprise.
In general, we can help form change in the hospitals and stuff like that, but we're now talking about kind of a little bit more of a broader umbrella. And
so the ambulance service, okay.
Yeah, and we've engaged with the National Ambulance Service for this as well.
And are they for this? Would they like to see this?
There are certain people that are for it, yeah, absolutely. Certain senior stakeholders.
That's a politician's answer. There are certain
it has
people.
been look, to be honest with you, Laura, I've had veiled threats on my career since opening my mouth about this. I have been told by senior people in the HSE that I need to look after myself and that I need to watch out for myself. And if people are afraid of what I have to say, but also what the rest of our group has to say, and the rest of our group has between 60 and 80 years of HEMS experience, I feel like it's time they need to start listening. It's not just a little blonde Lisa that's knocking at a door from Mayo. I am a very small fish in this bigger group. And we have patient advocacies, I can never pronounce that word, in the group as well. And that's when we have our meetings every week with this group, they're the ones that bring us back down to earth. They're the ones that are like, it's for my family. They've lost loved ones in road traffic collisions or in traumas. And it just stomachs us every now and again because we might get nitty gritty details, and we're like, oh, well, it's 37% of this. And you go, well, actually, this is our colleague in this group. Their loved one is part of this statistic. And it brings it really back home to us. And I think this is really important because we might go off on a tangent to talk about this, but actually they bring us back down to say, this is the why that we're doing it. This is, their loved one, Mary or John. And they'll use their names. You're kind of going, oh gosh, this is the loved one that we know is part of the statistic, and this is what we keep fighting for. So yeah, there's a little bit of barriers. We're still bursting through, and I do feel that we will be successful.
You referred to yourself there as little blonde Lisa. So is that to do with the fact that, well, obviously you're blonde and female. Is there a little bit of that going on too with the pushback, do you think?
Because 100%. We're talking about, they're all men. They are all men that are there, and they're men that have been there for the last 15, 20 years. And like I said, trauma care has absolutely hugely changed in the last 15 years. So what we do with, the UK trauma is very applicable to what we do here. What we do with the Northern Ireland trauma, just across the border, is very applicable here. We need to change to go to the international standard. We are one of two countries in Europe, the European Economic Area, one of two that do not have doctors in the pre-hospital. There's 32 countries, we ourselves in Cyprus. Now that came out in 2022 in that publication, but actually Cyprus are putting doctors into their pre-hospital. So very soon we will be the only one in the European Economic Area that will not have doctors in the pre-hospital. And that is what? How are we such an outlier with this? And even with our road traffic collision deaths, and I'm very careful to say that what we are advocating is a very small piece of the jigsaw that will help with reducing down the death rate that's there, because the evidence would show that if you have critical care that happens to be physicians, because that's what we have and available to us, you will reduce mortality, morbidity in trauma patients by up to 37%. That's there. I can't change that statistic that has come out from international evidence. So, it's one part of the jigsaw of many, where many different departments and many different groups are trying to change. But we're a very small fish. But we know what we know. We have all the experience that we have. If they could just listen to us. Now, hopefully we're going to be meeting with the Taoiseach. He did say in May that it would be remiss of him, I think is the word he said, that he would not, if he didn't meet with us as frontline, he wants to listen to what we have to say. But maybe the summer's just put a little bit of a stop to that.
Well, we might just give him a little shout out now when I'm putting out the podcast.
Do you know, in fairness with the media have been fantastic with this as well. There has been many journalists that, and Ireland is small, we all know each other anyways, but, I would talk openly about kind of, say, emergency medicine, or, when there was trolley crisis, is trolley crisis. So you build up connections along the way. And oh my gosh, all the journalists are like, Lisa, you need to keep talking about this. Not just me, by the way, sorry, it's the rest of the group as well. Now, the rest of the group are a little bit shyer in coming out, and especially with what has happened to me from the threats, the trolling, all the crap that's happened with that. They're seeing that, oh God, this is actually, causing a huge amount of kind of just a little bit of uncomfortableness for some people, because it's all got to do with change. But they are going to come out a little bit more, because people, it's not just me that's saying this. There's a whole group behind us that are very much wanting this to happen.
And are you worried for your job? Being so outspoken about something when in an environment where people are resistant to change, particularly if they see their own jobs being threatened. Is that what people think?
That is something that could happen, but I would prefer to be like, we can all do this together. And we can, because the skill sets that we have in Ireland, if we could just all work together, rather than saying, you're out of a job, you're out of a job. No, I wouldn't be even thinking that. We're all working for the benefit of the patient. At the end of the day, once I advocate for a patient and I have proper information behind it, under the medical council, that's part of our medical council, that we have to, if we see something wrong for a patient, if we see something bad happening, we have to actually open our mouth and say. So it doesn't matter what my contract is. If I'm advocating for a patient and I'm doing it in the proper terms, then yes, absolutely, I could do that. So if I'm going around and slagging off and slating, which I never do, we can work together. We're a really small island. We can absolutely get this right. And we can actually have one of the best HEM systems, I feel, in the world, because we're so small. As in, we just have such a wide range of skill sets. We are totally applicable in the island that we have, as in that how we can get around the island. So we can do this. So I'm not worried, but there's always something in the back of my mind going, will something trip me up along the way? Will somebody take something up wrong and have to go through the channels through the HSE, etc. Like I've absolutely had chats before in relation to my social media, but I'd be very strict about my social media and my HSE guidelines. I know exactly what I can and cannot say on my social media for it. And I've been very strict about that. So, I'm pretty savvy enough. I'm media trained with, and I work with the Irish Medical Organisation as well, which is our union, to we have to advocate. We have to say what's happening for patients, etc., and try and always strive for change. So if that's wrong, then I'm fired.
Okay. And it's not just death that you're concerned about and worried about. If someone isn't looked after as quickly as possible for the trauma that they have, and they arrive at hospital and you stabilise them or whatever needs to be done, there is recovery there that is potentially taking months, maybe even years, that may not have had to have occurred if they'd had the original. So that would be the morbidity that we would look at. So say, for example, the most common example I could give you with this is somebody with a head trauma, a head injury. And there was a very good report in Cork that came out about 2 or 3 years ago that shows that actually we are very bad at managing head injuries in general in Ireland. And I mean, not that you've kind of had a little bit of a fall and knocked to your head. You're talking about gross head injuries where the brain will swell. If you treat that very early on to make sure that you can get enough oxygenation to the brain, which is the intubation, place somebody into a medical coma, give certain medications to help stop brain swelling that's there, so you're controlling pressures within the brain. I don't want to get too medical into it. The evidence shows that the recovery for that patient is absolutely so significant. And you're talking about reduction in rehabilitation times, reduction, getting back to work. So the majority of people who have the road traffic collisions are patients, they're men, they're between the ages of 18 and 25, is it? So these are people young
that have to contribute to the society, have a whole life ahead of them. So we know that if these interventions are done earlier in the patient's clinical course, it affects their morbidity, which is their outcome. And I mean back to work, not really back to work, but back to society outcome. How can they function? How can they live independently? And that may very well be that they have a shorter stint in hospital, reducing infections, reducing etc., shorter stint in the rehabilitation. There's loads of things that has that knock-on effect for the person. So that's just one example of many that I could give.
And you did say there's 3 of you that are trained. How will we recruit the doctors if this does come on board?
Oh, that's a really good question, because that is something that lots of people have thrown back to me. We don't have enough doctors for it, or to keep the doctors in the emergency department. Wales done this very good. And the guy who set up Wales Air Ambulance that's there, I'm very much in contact with him about this. it actually caused a huge recruitment drive for them. So they actually got a huge amount more consultants coming into their country.
This is doctors just want to be riding on helicopters.
It's
These
about
mad doctors.
It's about, but it's not just about helicopters, by the way. We have rapid response vehicles. So if we can't fly, then we go on a rapid response. So, it just happens to be the mode of
Are you
transport.
adrenaline junkies, really?
Absolutely. Of course, emergency medicine would be. It would be. You love that sort of, but it knocks a lot out of you afterwards. But in Wales, they actually showed that they had an increase in the amount of consultants coming into the country. So it was a recruitment drive when they actually coupled the job of consultant emergency medicine or consultant anesthesiology with whatever, 1 day a week on HEMS in the pre-hospital, etc. So we will get inundated, I would say, with the amount of, because there's a lot of people waiting in the wings from the UK and Australia that keep messaging going, Lisa, what's happening? Is there anything, happening at home, looking to come home? Because also, remember, at the end of the day, this gives a bit of a job flexibility. Emergency medicine, I love it. I absolutely love the job that I do. But you could definitely tell at 37 hours when you're seeing, or even 37, 60 hours in the emergency department, you're seeing the patient coming in, central crushing chest pain, radiating to the left arm, and you get fatigued because you're seeing so many things over and over again and you're tired from it. So actually, when you have that change and a mix of your job, it refreshes you and it fills up your little positivity cup, and you're actually going between filling yourself up and then really focusing on the patient again.
It makes life interesting.
Yeah.
Because like that, I think people might think, it's really interesting what you see day in, day out, all these different things, but you're probably seeing 90% of the same things all the time.
Yes.
So in order for even your job, as you say, filling your cup up, feeling like as if you're upskilling or parallel skilling or whatever you might call it, it forms that, I suppose, full circle of job satisfaction too.
Absolutely. Yeah? The job we do in the pre-hospital in the UK, I always say the medicine is the same. It's the exact same as if the patient is in the emergency department to me, the medicine is. But it's just interesting that I'm now doing my intubation while kneeling on the ground and looking at a little spider beside me going, oh, Jesus, Mary and Joseph. Or doing, like, we were doing an art line, so you put a line into somebody's artery there to really monitor the blood pressure. And I remember one of the first times I'd done it in the pre-hospital, a little bee landed on me. And this is like an aseptic technique. And I was like, this hasn't happened to me before. The medicine is all the same. I've done this so many times in the emergency department, but a bee has never landed on me. So we do that. So it gives you the interest, kind of going, how do I, the paramedic said, I just done a little wobble, but I actually didn't move my hands at all. Like I done this little shimmy. So that sort of aspect of it. And we look hugely in the pre-hospital at our human factors, because we know that the medicine is the same. We know that, we can do the same things that we, blood, etc. We train so well for this. And even if there's days that maybe we don't get a job, not too often, but if there's jobs that we don't get a job, or days that we don't get a job, we're not sitting on our Todd like, drinking a cup of tea. We have to actively keep up our training. So we have to do moulages, we have to do simulations, we have to do all of this sort of stuff. But the human factors aspect is amazing and I love it. So sometimes you'll have one of the other consultants that'll come on, they'll third wheel with you and they'll observe you and they observe what you do, your techniques, everything about you, and then they give you feedback at the end of the day. The most common part of this is the human factors. How do you interact with the ground crews, with the patients, with other, maybe the police over there, etc. And I love it. I love that whole aspect.
Sorry, I thought the human factors, I thought you meant the things that can go wrong via human error.
Yes, that could happen too as well. So we always try and mitigate that. So say, for example, and we love looking at that, if something does go wrong, like what I'm saying is, okay, let's see. All right. So there was one day that I had a patient, one night, it's 2:00 in the morning. The patient had fallen and banged his head off the door handle. So he had his injury, like he'd pushed his head back. He had a very high C-spine injury. So we knew straight away that there was difficulty with his C-spine. He was getting flaccid. He was, his arms and his legs, his blood pressure was going low. So we knew that the spinal cord here was under a huge amount of pressure. He had nothing else wrong with them. And we needed, his breathing was started to go as well. So that part of your spinal cord will affect your breathing.
So Lisa is actually pointing to the top of her neck almost. So it's
high C-spine.
A high C-spine, okay.
That helps to keep your diaphragm working. Mm-hmm. So when that starts going, your diaphragm is going to stop working, or therefore you will stop breathing and therefore you will die. So when you have somebody with that, you have to put them into the medical induced coma. So you have to intubate them to take over their breathing, because you know that in another 30 minutes, they're going to stop breathing. So we took the patient downstairs. we went to intubate him outside. So intubation is one of the most critical things that you can do for a patient. You're taking somebody who's sitting up talking to you, well, he's lying down talking to you, saying that he was struggling to breathe, and you're putting him into a medical induced coma. And it's a very short time frame that you can do to get this patient safe in a safe configuration. And also at this moment in time, he has his high C-spine injury. This is what we moulage for. This is like clockwork for us. So the critical care paramedic that I was with, so he prepares the equipment. I do the intervention. Now, there's always a time that we will swap around so that he knows how to do the intervention as well, if needed. And that's one of the times that it happened. So when I went in the first time to have a look in to I gave the medications, the patient was stopping breathing because that's what you have to do to be able to do this intervention. And I remember looking in and I couldn't see anything where I was going at all. The light was working, but I was like, wow, it's just a big tongue. I was like, oh gosh, okay. So I came back out again. You only have about 20 seconds, or else you don't want the oxygen levels to go down. You start giving him more oxygen. And I was talking with my colleague, I can't see anything at all there. So let's just go to the next section. So we have a failed intubation plan, and it's so chilled and calm. So we do a few extra maneuvers that we were doing with them. Went back in again. Absolutely nothing. I couldn't see anything at all. Came back out again. I was like, okay, Chris, the third thing that we need to do, and it was to change provider, change the person that was doing it. So swapped over. Chris went and done it, my paramedic colleague, and he was unsuccessful as well. So, but it was so chilled and calm. We were able to rescue in the way that we know how to manage that. And then we went on to the Royal London. That was the hospital that we were going to. And I remember thinking, oh my God, because this is your most critical intervention. And this was really, really hard. It was very difficult. The two of us had tried it. We had our failed intubation plan, which worked very well because we'd done all our things that we needed to do, but we were still unsuccessful. And I remember coming to the Royal London. We had a 30-minute journey, but we were monitoring. We were able to secure some sort of an airway for him. Everything was perfect for him. His oxygen was fine. And I remember coming into the Royal London and my colleague, Sammy, because I had radioed in and said what had happened, he just put the hand on my shoulder and he goes, don't worry, it happens, the best of us. And I was like, I'm fine. And the tears literally just started streaming. So the consultant anaesthetist was there, and a fellow was there, a fellow that was in airway. And they tried and they were unsuccessful twice to get it as well. Now the third attempt they got it. And I stayed around. What was wrong? So it was really interesting because the consultant anaesthetist came around to give me a really good debrief.
I thought you were going to say give me a really good hug.
No, give me a hug. He said to me, there's nothing you could have done differently. And my colleague was there as well. He said there was nothing you could have done differently. If this patient had come in for a normal routine operation, like if they had their, getting their, gallbladder out, he said he would have given us the same problem as well. Whatever anatomy that this guy had, it was just very, very unusual. And also because he had hit the back of his neck, it had pushed, because there was a swelling started, it had pushed a lot of his anatomy forward as well. So it was quite hard to get to it. I wish I had one of those little watches on to have my pulse rate, because I don't think I would have went into any way of a stress mode. Afterwards, going home, I was like, what the frick just happened here? Okay. Oh my God, that was so stressful.
Yeah.
But when we practice so routinely for something, and we practice for if something goes wrong, if there's a failed intubation or if there's a failed something, we practice so much for it that it's like, okay, let's just inactivate plan B, please, plan C, please. And then we just go through it. Even I remember during that scene, it was so cool and calm, but I remember somebody coming up to me and they said, do you want a blanket there, love? Right? And I was literally in the middle of, I was like, no, I'm good, thanks very much. But they obviously didn't even know that it was a stressful situation for us, which we talked about afterwards. I was like, maybe I didn't communicate that out to the team that we were having a difficulty, that we were so chilled that we were doing this so well. And that was a human factor point that we brought up about it afterwards, that actually the communication to the rest of the wider team. I mean, this person was one of the ambulance crew that was standing by the wall, and just came up and thought I needed a blanket to lean on my knees, in the middle of a critical intervention. So that's
calm in a crisis.
Oh my, I'm so chilled. You will never ever know that I'm stressed at all unless I'm at a Gaelic match. So I'm so chilled in general with it. You'll never know. No.
Okay. So what are the next steps then? Just keep harassing people?
We'd like to say that we'd like to have engagement with people. Okay. So further engagement, yeah, because we have our plan more or less done out of how this could be implemented, right down to the euro, right down to exactly how we could do the recruitment drive. We're not unveiling that yet, obviously, because we want to have it proper with the senior stakeholders like the Minister for Health and the Taoiseach to say, yes, that sounds okay. No, it doesn't. And look, if they turned around and said, no, that's not going to work, I really feel like then I'll say, right, okay, book closed, chapter is done. I've been told by the senior people that rule this land that this is not applicable. And, I would have felt that, okay, I've tried my best. Would I be happy? Probably not. I'd probably still keep going with it. But even just for them to hear it, because we've had such a positive engagement with Minister Chambers, who's also medical by trade. Like, he understands it, he understood it. And we had a really good meeting to say that this could be implemented. And the next stages, which was to meet with the Minister for Health and the Taoiseach, will really say what our plan is.
And surely it is cost saving in the long run.
Absolutely.
To have a service like this.
Yeah, and there's been loads of studies showing that from Australia to actually, when you say cost saving, it's cost saving for the hospital but also for society as well.
That's what I actually meant, society, and for the person to whom the accident has happened.
And their family.
Yeah.
And their family. Yes, absolutely. There's so much to show that but this is public health. This is public health. This is, the road traffic collisions that are happening now is a public health potential emergency. And I don't even like saying that because, I think that does, there's all epidemics of this, that and the other. But we're having an increase in it and we need to find out why. I feel that critical care aspect of it is a small part of it. But if we treat it as a public health emergency because people are dying from these things, it kind of makes us go, right, well, we really need to look at all aspects of it. This is affecting every section of our society and affects every age. For emergencies for patients when they ring 999 for paediatrics, it will more than likely be a trauma that you will get for a paediatric emergency rather than a medical. So say somebody cardiac arrest or a diabetic paediatric. Trauma is the most common thing that you will get the 999 call for paediatrics and get that response for. So like we're talking about young kids getting knocked down. We're talking about young men at, very good early age to have a whole life ahead of them in college, contribute to society, live to populate Ireland again. Like, you're talking about these people. And of course, then you're talking into the next section would be kind of the 40 and 50 year olds that are somebody's mother, that's, that's somebody's father, a brother and a sister. So every section of society it is. Yeah, absolutely. Yeah. And
are you talking about as well having doctors on normal ambulances to be able to do the work there and then with them too, or is it purely?
I'm mainly HEMS. I'm mainly about the helicopter emergency medical system, but there is another branch called CEMS, which is Community Emergency Medical Service, and that's in the UK that we would routinely so they would go to. They're kind of like lower acuity calls, so they will go to somebody maybe in their home that maybe may have a urine infection, that can't get to their GP or can't mobilise to get to their GP, etc., or needs to get an ambulance. They think that they need to go to the emergency department. And actually CEMS in the UK are able to prescribe antibiotics, do dipsticks, to manage that patient there. So it's a community emergency medicine service. The National Ambulance Service are rolling out the community paramedicine and they are amazing. So that will be increasing their skill set to do basically that, which is fantastic. And I've met one or two of them. And oh my God, there was one of the ladies, I think her name is Breda, she's from Dead Limerick. I listened to a presentation from her last year and the cost savings that she and her, I think there was 6 of them in the country done for the HSE in relation to not needing to have to come to an emergency department or access the GP if they couldn't get into their GP, but actually keeping them at home for minor ailments, minor conditions, etc. Kind of like, I suppose, we could utilise the pharmacy.
Well, sure. Listen, this is what the Irish Pharmacy Union are talking about now, and I think there. Obviously, all the stakeholders have to be involved in it, but we definitely can increase the services that we can give to patients. And
I kind of feel guilty saying that because I feel like I'm throwing a huge amount of workload then. I'm going, that would be fantastic if pharmacists could do it.
Obviously, look, we'd have to relook at all of the onerous paperwork that we have to do instead of going patient facing. But absolutely, like we're highly skilled and trained to do some things that say could take all of that stuff away from say emergency department, primary care doctors as well. But that's another conversation.
I started saying this for patients in the emergency department, if they came in, like we had one recently that came in with a wee bite. Like I'm actually covered in bites now, so I have, because I was at garden at the weekend, but they came in with a wee bite and I would always say, and did you go to your GP first, and did you go to your pharmacist first? And they're like, no, sure. Why would I go to the pharmacist? I'm thinking this is exactly what you could be able to help them and direct them with and give them a bit of information. But, to come to an emergency department, which people do with. And it's, for me now, my job then is just to information load to them. Go, oh yeah, the pharmacists are very well able to do this, and you'd get a huge amount of information from them, and you might have to wait 20 minutes, for them, but it's better than here, isn't it? So you say it in a very nice way, and it's an opportunity to say to patients that there are other points of access. The HSE have a really good thing called undertheweather.ie as well for any of the paediatric patients. So when you have mammies and daddies that are coming in, that there's a really good website there, and I've used that a huge amount. Just again, education loaded onto the patient to say that's maybe a potential, because they might go back and have a cup of tea with a friend and say, oh yeah, she said something about this.
I know, and it is actually, it is, if you just give them the knowledge, because it is amazing what people don't know. But once they're told where to go to get the knowledge, then they do know it for the next time. So it is great.
It has really surprised me, the amount of people, and this is something that I would take for granted, that people do not know that there are no doctors on the helicopters, and that they feel that there are, just when you said about the knowledge, and I'm sorry for going back to this, but even some of my close friends will be like, sorry, what? Like, how are you saying that?
I said it to my brother there. Yeah. He's like, huh? Because he lives in Australia, so he'd be totally used to that.
So the general population do feel that, oh God, thank God the helicopter came. You're like, well, the helicopter is an ambulance. It has the exact same skill set as an ambulance, which is the advanced paramedics that are on it. So it is a flying quicker machine, but the skill set is the same. People are like, oh, didn't know that. And I take that for granted, that that's something that I thought everybody knew.
Well, they'll know now, Lisa, because we'll be shouting about it. Lisa, what makes a lady like yourself want to get into emergency medicine?
I firmly believe it was the Order of Malta. we do this pre-hospital first aid. When I was 15, 16, I was competing in All-Irelands for first aid. I won an All-Ireland for first aid. And
what? There's a first aid All-Ireland?
yeah, there is.
Jesus, there's competitions for everything.
Everything and anything. We have a team first aid competition, and that was in, it was actually in Wesley College. That's just around the corner here. Is that Dundrum?
Yeah.
Is that right there?
Yeah.
And we had, so the scene, you get a scene basically, and you have to treat the patients within 20 minutes. You're talking about 15 or 16-year-olds, and it was an unresponsive patient, so you had to do airway control and put somebody into a recovery position. There was a fractured femur in it, so you have to do basic management of non-pharmacological management of pain, which is immobilising, and the splinter, or the splints that you get, and the retainer bandages to put them all together. So there's loads of that. You also have orals in it as well, so you get oral kind of questions about certain aspects. So I remember my oral.
And you did this for fun?
Yeah, it was fun. We won. It's the Digby Cup, and we won it. Myself and 3 of my colleagues as well. 3 of us in total are actually in frontline healthcare service, so 2 nurses and a doctor. And so this is where it kind of all stems from. And I remember my oral was like, what is hypoglycemia? Okay. And I'm sure if you ask a 16-year-old, they'd be like, hypo what? And you had to give the verbatim, like what it is. I remember seizures or epilepsies, the tendencies, fits and seizures caused by brief disturbance of the electrical activity of the brain. So this is what you were learning at 15 and 16. Well, I joined when I was 13.
What is the Order of Malta?
The Order of Malta, Ambulance Corps. Absolutely not. There's 2 aspects to it. There's a very traditional aspect, but I'll say the Order of Malta Ambulance Corps, which is what everybody may see when you're out at like the Bray Air Show or, at football matches normally around the country. You would see people in uniform with the ambulances that are there. That was set up in Galway in the 1940s, I think it is. It was done by a doctor actually that wanted to get first aid to people, kind of like what I'm doing, but actually on a very lesser scale. Trying to get first aid to people in the pre-hospital and having trained first aiders to try and get to them. And then it just developed from there. So the Ambulance Corps is only in Ireland. The Order of Malta Ambulance Corps is only in Ireland. I'll explain about that in a few minutes. It's voluntary. We have probably between 3,500 and 4,000 members, but we do first aid, but we also do community services as well. So there might be stuff like maybe doing a mass run for the local, elderly population, or we do. There's lots of different aspects to it. So it's not that we have 4,000 people just out on duties. A lot of our members are first aiders. They will be in CFR groups as well. There will be
What's CFR?
Cardiac first responder groups around the country. So they will go out voluntary as well with them. Emergency medicine technicians. And actually we do have paramedics and APs in it as well. So that's also, they do their day job with National Ambulance Service or the other privates, and then they're also voluntary with us.
What's an AP again?
Advanced paramedic.
Oh yes.
So
Sorry.
and doctors and nurses. We have a load
and your
of them.
little abbreviations.
Oh,
I
I'm
just
so
can't
sorry.
keep up.
I tried to keep it
I know.
way. But so we have load of people that will, and we just really enjoy it. I mean, it's a really good, we do loads of social, we do competitions and that sort of stuff. So it's kind of like a group that we can, meet and have that kind of, I suppose, similar interest. Is it religious? The Order of Malta Ambulance Corps
I didn't ask you that, but in my head, that was my next question.
Oh, dude.
Telepathy. Can you hear
Because
what
I
I'm
know
thinking?
where it's going next, though, with
Okay.
this. So the Ambulance Corps is only in Ireland. It's not religious in Ireland. It will be, it's a Christian organisation, but you could be any denomination to come into it. Like it's not, you don't have to be like verbatim of the Bible to come into it. Any creed could come into it. Anybody could come into it. Doesn't matter. The Order of Malta Ambulance Corps is part of the works then of the Order of Malta Association. So the association is kind of like the umbrella part of it. And that goes back then to 1099.
Okay.
So you're talking about like the Knights Templar, all those knights and dames that you would have heard about that would protect pilgrims that were going to the Holy Land back then. That's when our Order of Malta Association actually began in the world.
What's the Knights Templar?
They're a group of knights that would help to protect people that were pilgrims travelling to the Holy Land from all around the world. So
The Holy Land being?
So Jerusalem and Bethlehem and, trying to go and, pay their respects, etc., when they would go on pilgrimage. So what would happen back then is that as a journey for a pilgrim to do that, it would be very, very dangerous, of course. So people of faith, which was the knights and the dames. Now, the dames normally had more of a hospitaller role, meaning that they would tend to your sore leg and they would give you food, etc. Whereas the knights actually would help you and defend for you if you were being attacked by other creeds going along the journey. This is as simplistic as I can make it. So that's where the Order of Malta Association comes from. And it is a very traditional organisation. It is very Catholic. It is very chivalrous. It is, so we have knights and dames in all different countries around the world. We have a diplomatic status as well. So there are certain higher parts of the Order of Malta Association members that have their own passports from the actual title is the Order of St. John of Jerusalem of Rhodes and of Malta. Okay. So we would have been part of kind of like in Malta when they defended the island to keep the Turks out. That would be a very famous battle that was there. So that's kind of the whole history, like what, a minute or something like that. Yeah. So where it comes down to today then is that the order, our main thing is that we do good works for people. We don't care about what creed you have. If you fall in front of us and you need aid, if you need, so some of the works that they do is actually they do a night run in town here in Dublin so that they would collect socks and gloves and stuff like that. They would give them out to homeless people. That would be part of the works that they would do. So it doesn't matter. So you're not saying to somebody, oh, are you a Catholic? We'll only help Catholics. But it's for us, we are Catholic and we will do the good works of God and we will just try and live a humble life and be good to everybody. So our Lord's the sick and our Lord's the poor is what we go by. So if we help our Lord's the sick and our Lord's the poor, then that's just what we do.
Say that more slowly.
Our Lord's the sick, our Lord.
Our Lord is the sick.
No, our Lord's the sick.
So whoever is
the Lord has that is sick, and whoever the Lord has that is poor, we will help them. So our Lord's the sick and our Lord's the poor is that we help. And this is all around the world. So this is in every country around the world. And in Ireland, we have that as the traditional aspect as well. So I'm a dame, Bernard is a knight in it, so the title will be
Who's
Dame.
Bernard?
Bernard is the husband. What do you call him? What do you call
Mr. Fabulous?
Mr. Fabulous. Mr. Fabulous.
He's your Mr. Fabulous.
Yeah, I know. I was like, don't say his name. So I don't have any title for that for Bernard. It's like Bernard.
Bernard's fabulous in his own little way.
Oh yeah, absolutely.
He is.
Absolutely.
So he's a knight and you're a dame.
I'm a dame. So
and you dress up in this big black cloak sometimes as well.
Yeah, so that's the traditional sense of it. So the cloak that I have and that Bernard have, so we're different, but I would have a cloak, you would wear a mantla, so you cover your head going into mass. When we do our masses, when we do our pilgrimages, etc., there's so much symbology behind everything with it, because it is a very traditional order. And even when you become invested, which is the term that we use to become a knight and a dame, and you have to be chosen to become a knight and a dame to do it, you make a vow to defend the faith. Now, I'm not going out taking up arms or anything like that, but that would have been the traditional aspect of it. And I really, really, I love history anyways, but this is just a really nice aspect. But not many people would probably know this as a side. Like, I don't go around to Sunday Mass and wear my mantla. I don't go around wearing my cloak for a normal Mass. We would get together and we would have masses and celebrations, and we do pilgrimages like to Knock. We'll go to Knock. We go to Lourdes every year, those sort of things. And we help our lords the sick and our lords the poor.
And were your mum and dad involved in the Order of Malta, or was it just you got involved
just
by
me.
this?
Well, I got involved with one of my best friends, Denise Gilroy, who's on the All Ireland winning team. Woohoo, yuppie baya. She said to me, we were in first year, and she just said, "Here, will you ask me a few questions out of this book? I'm going to be getting a quiz tonight." And I'll never forget where I was in the 1A2 prefab. And I was like, "Oh, what's this?" I was like, "What's a weaverfish sting?" And she had a trotted out on a weaverfish. So I was like, Jesus. And then I remember flicking through, this is actually really interesting. And she was like, "Sure, come up to the thing." It was 50p for your subs on a Friday night. I was like, sure. I didn't have to pay it the first night. But then I was like, oh, geez, this is actually quite good. So it was every Friday night. That's how I got involved then, was the weaverfish sting in the first aid book. And then, oh God, Bernard said it to me the other day, I think we're nearly 10 years invested in the order, which is scary, how quick that it's gone. So we're in the Order of Malta Ambulance Corps, but then we both got asked by a very senior person if we would like to become invested. And then you go through a year of, you have to do certain aspects of either retreats or pilgrimages, etc. But we were already doing them anyways as part of the Order of Malta Ambulance Corps. So we go to Lourdes anyways. Right. So then we got invested, yeah.
Okay. And
no, Mum and Dad weren't in it.
Okay. And are you very religious in your day-to-day, or do you believe in what the Bible teaches us about Catholics, or how we should live our lives, or whatever?
No. I'm Catholic and I'm very faithful, but there are certain aspects of the Bible that I absolutely don't agree with, and certain aspects of the teaching that I don't agree with. And I think the term is modern Catholic now. I mean, I have an uncle-in-law who's a priest, and I love having chats with him about it. And I'd be like, "Did you hear about this? And what's going on here?" And he goes, and I love it. He just goes, "Does it change your underlying faith?" No, it doesn't. Well, then just stop with the white noise. Concentrate on what you feel your faith is for the Catholic. And I'm like, that's it. So if they say stuff about, you can't be gay, I'm like, you do you, whatever you want to do. And I have loads of friends who are gay. I don't live it to say, "Thou shalt not be gay." So I will do what I need to do to have my faith. I won't ever impose my faith on anybody. And I think that's really important, that when I work as a doctor, my faith stays at the door. I will never impose my faith onto somebody, on a patient that's there. Now, if I have, say somebody who passes away, internally, I say a prayer for their soul, and I feel like, I've done my bit. I've been with them at their time of passing. I might hold their hand. It's amazing the amount of people that are very still religious in Ireland from a Catholic faith, and they would absolutely want a priest called. They'd have their last rites, and the family would really want this as well for people that are there. I haven't been too exposed at the end of life care for maybe other faiths, and I think that's maybe just because of the demographic that I have. But in the UK, definitely we've had other faiths as well, and I'm interested to see how they have with their end of life as well. So my faith stays at the door. You will never know that I'm a practicing Catholic, a modern Catholic in my work. I never let it influence it, and nor should it for any faith.
Yeah, fair enough. So there's a little bit of an age difference between yourself and Bernard, isn't there?
There is, yeah. There is, is it 12 years? So he's 50, I'm 38. Yeah, so he'll be 51 later, yeah. So, yeah, it's never ever bothered us. I don't think anybody has really said it. I think when I was going off to college, people were like, just... Because I was a poor student. Bernard had a job. It wasn't a great job or anything by any means, but it was just kind of like, oh, he's supporting her now through college. And then when it was I qualified as a doctor, oh, did he know he was onto a good thing? And then, Bernard set up his own business as well, and I'm a consultant now. Well, the term that I heard recently was like, well, money marries money. Oh, I was like, I went back to college with 50 euros in my pocket after everything was done and paid for. And if I got a good bag of shopping for my mammy with the special milk that had vitamin D in it and omega, my mum used to always buy me the omega milk because I don't eat fish. She'd be like, that's for your brain now, Lisa. And I'm going, I think I've done okay so far, but thanks very much for it, rather than Tesco milk. So yeah, we had, huge struggles throughout, not from a relationship point, but like I wanted to do my career as an emergency medicine consultant, and it was going to be moving around the country, popping out kids, and he's going to have the kids at home. And, I see ya, I'm off to Crumlin now, moving across the country, and then Vincent's afterwards. And we would check in every 6 months going, are we still on a good track? What's the crack? Like, am I still okay with the career? And there's been many times that I was like, oh, geez, you know what? I'll just jump off. I'll just do something easier instead, or not do as much of the training, because I wanted to stay at home in Mayo. And it would be very sad having to leave everybody on a Sunday evening and go back or something. And, we got through it all, and we laugh at it now because we're saying this is the time that we've always been saying for the 10 years, going, I can't wait for this to happen. I can't wait now for us to be able to go away for a weekend. I can't wait for us to actually sit down and not have to worry on a Sunday evening about going back. We're loving it now. We're really enjoying it now.
That's great. But God, it takes a long time, doesn't it?
Oh, you just see the tip of the iceberg and people say, oh, that's grand, money marries money. And you're going, Jesus, the amount of torture that we've had going up that iceberg, to the top of it. And I don't feel I'm at the top of an iceberg. I really don't. I feel like you put in the hard work, the hard graft, and short-term sacrifices give you long-term gains. That's my main thing, that you will get there in the end, you'll succeed. Do you know, we had a surgeon. He was he a surgeon? No, he was a medical student, and he wanted to do surgery. And this was only recently, and we were chatting anyways, and he said he wanted to do surgery, and he just goes, oh, but it's just so long. And I was like, what do you mean it's so long? He was like, it's like 10 years. And I'm like, yeah, but that's what you need to get your skill set to be a surgeon. He was like, I just don't know, do I have 10 years now? He was 22. And I was like, sorry, what? And he goes, well, it's grand for you. You live here. I was like, hold on a minute.
Wrong thing to say.
Yeah, I was like, I have 3 kids. I went through 3 pregnancies. I went through all this. And he was like, oh, right, I could say. I was like, your generation just literally will put in that hard graft to get out the other side of it. I said, if you want to be a surgeon, I was like, you can't just do that in 5 years, and out the door with you, and think that you're going to be from the standard of surgery that we have. Anyways, he rethought about opening his mouth to get in front of me about it. But I was like, Jesus, you just need to put in that time and effort and work to be able to come out the other side of whatever it is that you need.
You need to be tenacious though, Lisa, as well. You've had 3 children while you've been on the training scheme, etc. Mm-hmm. Is it more difficult for a woman in medicine than it is for a man, do you think?
100%, and it still is, but we're getting there with it.
Have you had many roadblocks, when you became pregnant, you're nearly through your scheme, or you're on the scheme?
Oh, absolutely. So many times around the way that, not necessarily even just with pregnancy, but even just being a woman. When I open my mouth and what comes out versus when a man opens his mouth and what comes out, we are perceived very differently. And you will get this very often in a resus situation. So if I'm in a resus and there's a very sick patient that's there and I'm leading the resus, I've even find myself going into now, I'm a very cool, calm, collected. You will get closed loop communication from me. I will look you in the eye and I will say, we need to have 20 milligrams of ketamine, please. And I would expect you to say, okay, 20 milligrams of ketamine. And that's the loop closed off. You will go get that. And we will, and you're leading with this way. If I start going, how are you, Laura? Laura, will you get the ketamine there and get 20 milligrams of ketamine for me? And, you're just kind of, this is not the time for, having a bit of crack and having a bit of fun. I need to get a message to you and it needs to be clear and concise. We need to have it. I will say please and thank you. But people will say, well, wasn't she a bitch? Isn't she strict or stern? If a man says the exact same thing, and if it's to another man, they will be very much about, oh, wasn't he a great leader? He gave really good communication. So I find that very, very interesting with it. And we got, myself and there was a nurse that I was having a chat with one day on the corridor. And what was it about? It was about, there was paediatric patients that were going over to a certain part of the emergency department. And the nurse was saying to me, we don't normally take the pediatrics over here. And I was like, oh gosh, sorry, I didn't realise that. We can send them back, whatever. And we had a bit of a conversation, interaction on the corridor. Nothing major. I know this nurse for years, and anyways, that was fine. And then went off. And then Deirdre came back up to me later. She goes, Lisa, was I really rude to you earlier on? I was like, when? And she was like, when we were talking about the paediatric thing. I was like, no. And she goes, one of the doctors pulled me aside and said, do you not realise she's a consultant? How you spoke with her really rudely? And I was like, sorry, what? And it was a male doctor, and it was actually a doctor that wasn't from Ireland. So he obviously was standing nearby, heard our interaction. I was like, Deirdre, our chat was very much, it was
matter of fact.
Matter of fact, she had something to say. I took it on board. I had done something that wasn't the normal protocol. She corrected me in it, but in a nice, there's no feck way that I thought that it was a bad way. And she was like, okay, God, because he'd said it to me afterwards that I was really rude to you and all this. And I was like, oh my God, that we had a great laugh over that, because I was like, that's because it was two females having a chat that was perceived by a man. And I was going, now you can know what it feels like in a resus, that if I'm having closed loop communication with somebody, you need to have, there's no time for kind of beating about the bush and being like, oh, I love your sandals here today. Here, will you grab the ketamine there over the shelf? Because that's where errors will happen. And I remember being in a resus once, and there was a consultant obstetrician, lovely lady. She's retired now. But anyways, there was a lady that was in front of us, and she was bleeding quite heavily. And she needed a medication. And she looked at me and she asked me for the medication. And I was like, sorry, can you repeat that again? And she said it to me again. And I still, in my head, the medication she was asking me for was something to slow down somebody's heart rate. And I was like, what the fuck? And she said, she pulled down the mask then because it was COVID times, and she spelt it out to me what it was. And I was like, okay. And it was a medication that sounded like what I thought it was. And then we got it, and I gave it to her as well. But again, another person said to me, they were just like, that was a really stern interaction. I was like, no, it wasn't. It was very much what needed to happen, because if I had given the other medication to her and kind of thought to myself, Jesus, why does she want this medication instead? I was like, it would have been detrimental for the patient, and it's not what you were given. So you need to have this. And it's not that you're being bitchy, but it's closed loop communication. I have something to tell you. It needs to happen. We're in an adrenalized situation, so you can't be flapping about the place, and it needs to be very clear and concise what I need to say to you. If somebody perceives that as being a bitch, then that's what happens. And it will always happen with the woman. It will never happen with the man. If you had two men that had that interaction, it'd be like, aren't they great communicators? They're being very clear and concise with each other. And we see this all the time.
Oh my goodness. And do patients mistake you as a nurse?
Oh yes, nurse, healthcare assistant, got mistaken for a shopkeeper once as well when I was in
shopkeeper.
Yeah, when I was in just grabbing a cup of coffee. Now, in fairness, I must have been standing kind of with a little bit of a glazed look at myself. I remember they came up with the Independent. It had to be funny. I was like, oh no, it's over there. You need to go. I will. And I remember one day recently I was going down the corridor, and we have dress up Thursdays. Well, actually, I take parental leave now on a Thursday, so I do dress up Tuesdays. So normally I'm in scrubs, but one day of the week I will try and put on a nice outfit and kind of come in, and it's normally my admin day anyways. So we had dress up Thursday. Now, my colleague, he's Greek-Italian, I'm like, we could come in our wedding dresses, myself and my female colleague, and everybody will say, oh my God, he's gorgeous. And he has gorgeous clothes. So we were walking down the corridor one day in the emergency department, and a patient came out of the bathroom and looked left and seen Georgius. I can say that, can't I?
Is that his name?
Yeah, that's his name. He's
Georgius. Like gorgeous.
I love it. Gorgeous Georgius. Oh, he is. He's just really well dressed. Saw Georgius, looked at me and just said, sorry, there needs to be more toilet paper in there.
To you?
To me. And I was like, no problem. And I was like, I'll get it. So I will get asked, I'll get asked, oh my God, so many patients to be like, sorry, can I have a cup of tea there, please? And you might be going to resus and you're like, do you take nickel or sugar? Like, I'll do it. Yeah, fine. And you'll just do it for the patient of it, rather than going, I'm actually the consultant that's here. And again, if you say that, what are you perceived to be? Well, is she too high enough to make a cup of tea for a patient?
I know. You can't win, Lisa.
You can't win. So I just smile and nod. And that's it. So, yeah.
And then in terms of your career, in terms of how you've got as far as you have you found it difficult having babies and doing the rest? Like, were you able to take maternity leave?
Yes.
Or did you have to go back early? Or
no, I was able to take my maternity leave. Everything was smooth enough for it, but I was one of the first trainees coming through that was taking maternity leave, and obviously 3 maternity leaves. So they didn't really know how much I needed to pay back at the end. So there's a bit of confusion about that. I had a huge amount of
training. Pay back, sorry.
So you have to pay back, like if I take 6 months off my training programme, I mean, that's 6 months that of a rotation that I've missed. And so of my skills, I need to make sure that I have proper time in the training aspect. So you do 3 years of basic training, and then you do 5 years of advanced training for emergency medicine. It's gone down to 4 now. So if I took, what's that, a year and a half, like a year, 18 months for 3 maternities, I mean, that's, a good chunk of my training. I have to obviously pay some of that back. So there was kind of a little bit of, don't know what to do with that. And I had to rotate all around the country. So there was definitely no flexibility in trying to keep you nearby at least, or
as in near your children.
Near your children, but even in one place. If I was to move to Dublin, say, you'll still get put down to Sligo, you'll still get put down to Cork, you still get put down to Limerick or whatever. So there was no consideration about trying to at least have it some sort of just a happy medium with it.
Is it necessary to be thrown around the country? Is it to learn different skills, or is it
to learn from a rural hospital and versus a hospital that has all the specialties at the centre? Much prefer rural hospitals because you have to learn the skill set. So say, for example, we don't have cardiothoracics in Mayo University Hospital. They're the ones that would do the chest and heart. So if you have fluid on your lung from a trauma or whatever, you have to be able to put a drain into that person's chest and drain it out, rather than having to go to Galway with cardiothoracics. But if you're in a centre where cardiothoracics are there, they may very well go, I'll do the chest drain instead. So you lose the opportunities for extra skills. Now, most often than not, when you rotate around, you'll try and ask them, can I be able to see you and maybe do the next one together, etc. So you have to still learn. It's still very much a practical learning job, and it has to be, because you learn through your hands, like you learn through the feeling of it. Just like surgery, it's like an apprenticeship with it. But I think that you get more experience in the more rural hospitals, because you have to do it. There's no way, or else you're sending the patient on another hour and a half up the road to Galway when they've already travelled from Belmullet. I keep using Belmullet, but it's probably one of the most beautiful places in Mayo, so it's really nice, but it's very rural.
So I know that you help with the ladies GAA.
Yes.
And obviously you're a massive Mayo fan.
Yes. How did you know? I will bring Mayo up into every presentation that I can.
Will they win?
Yes, absolutely.
But there is a little bit of a disparity between the ladies' football and the men's football in terms of even the care that the athletes get. Is that
yes?
Right?
Yeah. So
tell, Lisa, do tell.
Oh, I'm very open about this. So I'm also involved with the Mayo GAA setup as well, as part of the doctor in the Mayo medical team, as we say it, so with the men as well. And when I got asked to come in with the Mayo ladies, which was the first one, oh my God, I remember being so excited because I just fucking love Mayo and I loved the football. I was just very shocked within the first kind of like year going, what? Like there's nothing, no provisions for a doctor to be at the sideline for starters. I spent the first year as the doctor of the team being put back up to the stands, because the book says that it's only 3 people that are allowed at the sideline, which is the physio, the manager and one of the backroom team. Until then, Michael Moyles, who was the manager of Mayo at the time, the Mayo ladies, was like, hold on a minute, where does it say anything about the doctor? It doesn't really. So you're like, she's coming down here, she's standing there, she needs to be here for going onto the pitch. And they're like, oh, right, okay. Because the rule isn't there. There's nothing there for provision of doctor. And that was how basic it was.
Is that for the men's as well, though?
No, the men's are very much that they have a doctor, a physio, and again, the crew at the sideline.
But why would there even... That makes no sense.
I suppose the LGFA is in only 50 years, really, that's there. We are getting into the phase.
That's the Ladies
Gaelic Football Association. I think this is our 50th. Jeez, I better check that out, because I am coming up to the ladies football on Sunday. It's the 50th anniversary, I'm nearly sure. So we're still relatively young in the grand scheme of things, because the GAA is 1884 when it was set up. So we're getting there, and we are definitely, oh my God, we have just amazing advocates for the LGFA, for the ladies from all around the country, but we have fantastic ones in the Mayo set up as well. Lisa Cafferty is one of them, Fiona McHale. They're just, I sit there and I just feel my positivity cup going up when I'm sitting there absorbing what they're saying. Like, they're just role models that I am so happy that my kids, boys and girls, will be able to look up to. And the whole team is just amazing. So there's no real provision that's there. However, I will say, it is getting there. The management structure of it, even into the Connacht LGFA, oh my God, they're brilliant. They recognise they've taken a huge amount of my little kind of, can we do this? And they've taken it on board. can we get this paid for instead? And they've taken it on board. So what I do is,
so when you're talking about getting this paid for, and that, can you please just...
I will, because Mayo GAA, from what I've seen with the Mayo GAA setup with Dr. Moffat that's there, I'm like, oh God, they have concussion screening. How do I get concussion screening for the ladies? And he'll give me all the details. And then I'll say, right, I'll go to the Connacht LGFA. I'll be like, can we get this for the ladies? Can we get it paid for? They're like, yeah, okay, great. And so that's how I'm kind of like robbing from the men, as in like the idea is going, we need this. Can we get this here? So concussion screening, medical screening. And this year was the first year that we done cardiac screening. And I remember Dr. Moffat saying to me, he's the men's men's doctor. He said to me, it's really important to get this done. I think they get it done every 2 years, but he said it will be, once in 5 years that it'll throw up something for one of the players, but it means a huge amount that it's caught. So we done the cardiac screening with the girls, and our captain, Saoirse Lally, and she's been open about this. She's done interviews about it, so I'm not breaking confidentiality or anything. She got diagnosed with a heart arrhythmia. And I remember doing the screening with them, and I see the ECG, that it all goes back to a consultant cardiologist, but I could see on the ECG, I was like, oh, that's great. Great now, Saoirse, off you go now. And I'm like, any symptoms? No. And everything was no on the boxes. But I remember texting gorgeous Georges that night. And I was like,
I need to meet this person.
Oh my God, he's amazing. Because he has a huge background of cardiology. I was like, geez, I think that we've picked something up here with this girl. And I was explaining the bits to him. And I remember texting Sean as well, Sean Moffat. And I was like, once every 5 years, is it, that you pick up something? I was like, try like literally the first few minutes of it.
Wow.
So she got diagnosed and she got an ablation on her heart with it. And she has given interviews afterwards to say she had no symptoms. She thought she had no symptoms. She actually now runs better. She's not short of breath. She didn't realise that actually she struggled with fitness. Well, she says she struggled with fitness. Jesus, me standing beside her. I'm like, you're fit as a fiddle. But she said she never felt she could reach a certain level of fitness. But now she's just flying it. And she's still relatively young. Like, I mean, she's only, I think, 20 or 21. So that was a real prime example that I'm like, this needs to happen for the girls, for the ladies. And all the other counties, they don't, I don't think I know any, if there's doctors on them, on their teams. And anytime we go to any of the matches, so if we're playing like Armagh or Galway, I'll go to the physio and I would say, if you have a doctor, no, they don't. And I'll say, Grant, if you need anything at all for the girls. And like we had one where there was a Galway girl earlier on in the year, she got an ACL.
Oh, you don't deliberately like refuse care for the opposite team?
Not at all, no.
Right.
I don't. Like I feel, push her back down again. Only messing. But then I kind of feel like I'm going, I wouldn't make the call about taking her off unless the physio was there, because then obviously if like this is a really good player and I'm like, yeah, take her off, of course. So I will always say to the physio, if you need me, I'm here, and I'm here with pain management, etc. Because even recently they weren't even covered by ambulances. Wait till I tell you this story, right? And this really changed it. So we were playing a championship match in, I think it was in Longford, and I remember I'd always go to the ambulances and kind of say, what's the level, what's the scope of practice, and then how we go to get the patient off, where's the nearest hospital, what do you do, etc. Just kind of know in anticipation. And we get a lot of injuries with the girls, by the way, for a non-contact sport. So on this day there was only one of the girls, she was an EMT and she was on a rapid response vehicle. So if we had an injury, we would have to ring the National Ambulance Service to load a patient and go to a hospital, if you get me. So it was a car that she had rather than an ambulance. Does that make sense? So I was like, okay, grand. And who's with you to be able to take off the patient? Like if normally I'd give a hand signal if we need to get a stretcher off. And she's like, oh no, it's just me. That's all that was asked for. And I was like, oh, okay. So before the match started, I remember going to one of the officials that was there. I was like, okay, if we get an injury, I need to get somebody to help me. And they're like, yeah, we'll get somebody down from the crowd. I was like, no. Like, you can't just have somebody down from the crowd to lift a patient off. And this was televised as well as TG Car. I was like, what if we all trip over ourselves? We had two physios at the time on Mayo, so we kind of made a plan. Bernard was in the crowd as well, and he's manual handling trained and he'd know how to stretch off a patient. He's an EMT, emergency medical technician. So we had another person as well that I knew was trained. So we're kind of going, right, we had a half kind of, if something happens. Anyways, within the first 5 minutes, we had a 3-way collision between 3 of the girls, 2 Mayo girls and one of the other girls. Saoirse involved in that one as well. She broke her clavicle, but Eilish Renan had a dislocated elbow straight away. So this is the 5 minutes. So ran onto the pitch. I love dislocations, by the way. I love putting them back in again. So this is my kind of main thing. But I'm kind of going, like, how do I get her off now? Literally, I'm going, after everything that has just happened, I was like, the safest way is probably to walk her off. Like, and she had a dislocated elbow. Try to give her pain relief, but then I'm like, the pain relief, the Penthrox, which is the green whistle, I'm kind of going, it's going to make her a bit wobbly, and I don't want her to fall now going off. Oh, I was just so annoyed. Anyways, the shortest way off was to go down towards the goal. It was only a few steps. Ailish says that she doesn't remember any of this at all. It's all on video, like you can see it back. Like she's like, I don't remember any of this, because she was in such pain with it. So we got to the side of the goal and the match continued on. And I put her elbow back in at the side of the goal. And I remember thinking, I could easily get a clatter of a ball here. Like, we could easily get a clatter of a ball. This was so not professional. This would never happen in a Mayo men's match. So anyways, elbow went back in. We were able to walk her over. And then I was like, we're in Longford, grand. She needs to get an x-ray now to see where it is. There was just no way that we could even anticipate. We couldn't get her to a hospital because there was the ambulance that was there was a response ambulance. So it was kind of sit her in the front of a car, like with the, and also the girl that was there on the pitch had to stay there.
The broken clavicle girl?
Oh no, so she was pain managed and she had her sling on her. Sorry, the EMT that was there, she's employed to be able to stay at the pitch side in case another injury happens. Okay. So I can't remove her now from the game and say, here, will you bring these girls now to get their x-rays done? And it was only 5 minutes into the match, so I was thinking we'd have probably about another hour and a half. So if we could just go local, get a quick x-ray, see what's going on with them, and then we'll get them home to Mayo. Anyways, that didn't happen. I ended up having to send them home with their mothers in their car with another bit of pain relief and say, I'll meet you down at Mayo University Hospital at 7 o'clock this evening. I'll do your bits and pieces. And I was so annoyed because I was like, this would not happen. This is a championship match for senior ladies that was televised. And this was the standard of care that was being given to us. So Michael Moyles was the manager at the time as well, and he was fuming. He was like, Lisa, do what you need to do. I said, I'm going to write you an email tonight. It's going to be stern and strict. I said, it's not geared at you. I was like, we need to change this. So he forwarded it on to the Connaught Council then the following day. And then one of my colleagues who works in one of the private ambulance services was like, what the hell happened at the weekend? And I said, what do you mean? He said, they literally have been inundated with requests now from the LGFA for covering the rest of the championship. And I was like, good. So the standard of care now, we have, the ambulance is always there. We have two clinicians, normally a paramedic and an EMT. Normally, it depends on what, but they know now what to ask for. And it just took an instant like that to kind of raise it a little bit more to say. And we've had many injuries with the girls.
An instant like that and a woman like yourself.
To be like, come on, we need to up it. But is it the same?
But then what's it like then for the other around the country?
Yeah.
Like the Connacht's sorted, but what about Leinster and...
Yeah, like this is where we need to improve on it. And I do feel we're a small country, like as I keep saying, the physios that are attached with a lot of the other counties, I will be in quite a lot of contact with them and they'll say, Lisa, who's the contact for the concussion? Who's the contact for this? But as a result of that, they have increased the amount of pre-hospital, the ambulance being there at the side. So that is helping the likes of a team that mightn't have the doctor that's there. Now, I'm not saying that it's all the be all and end all. Most of our job is kind of done prior to a match. I get to sit down and kind of enjoy the match at that point. But then obviously if I need to get on, I get on for it. But it's the fact that even having it there, having pain management for the girls, like having Penthrox, having a proper splints and immobilisations for them, having a proper pathway to get them in for MRI scans. If they have to go in for an MRI, they have to hand over the money for a private MRI and then they will get reimbursed for it. The men in general will have the county board open up I don't know what's called, a PO or a standing order or something like that. So they'll go in and get their MRI, but it's all paid for in the background. No money.
They're not out of pocket at all.
They're not out of pocket. And the girls have to have that. Now, that's potentially another part that we could change with them as well.
But is it the same with other care that needs to happen? The girls just even going to the doctor and that isn't the men's care covered and the women's isn't?
So not for general care, not for primary care or anything like that, because I mean if they need the prescription for the pills, say,
No, I don't mean that. What I mean is if an accident happens on the pitch or they need care after an accident or something like that, the women are out of pocket in the immediate sense and it gets reimbursed, whereas the men can just go and get sorted.
Yeah.
That's really fair, isn't it?
It just needs to, I think it just needs to change. There needs to be a little pot of money so that if it was a case, And I'm just saying, even if it was €1,000 put aside, so that when the girl has to go for the MRI, the 250 is taken out of that pot and paid for, and then the reimbursement goes back into that pot. Do you know what I'm saying?
Yeah.
That it's not the girl actually having to hand it across or anything. And we look, there's lots that we can improve on, but that's just one example of it. But I will say the follow-on care. So if we have somebody who has an ACL injury or anything like that, I mean, they get the exact same standard. We utilise like the Sanitary Sports Clinic. And there's no question about it all there. They get the exact same standard afterwards, if that makes sense. In Mayo, they might not have as much of that pathway created in other aspects in other counties. But definitely physios would contact me saying, how did you do this? How, the secretaries in Sanitary Sports Clinic know me very well now. And, I would give out the details and say, this is what happens. This is how we go through it. But yeah, it's all about increasing that care for the girls. And it's only something very small, but it takes off any worry or stress that they have, because they need to focus on winning an All-Ireland or playing their match. So you really want to just make sure that they're not worrying about, God, do I have 250 now in my account to pay for this MRI if I get injured? That sort of way. Which,
of course.
Everybody will find it in a way, but it takes out one aspect of their worry and stress and lets them concentrate on a game.
Did you ever play for the team?
No.
Oh, you didn't?
No,
Did you ever play Gaelic at all?
No, not as a child, not growing up, but I do Gaelic mothers and others.
Gaelic mothers
and others.
Okay.
Yeah, and I absolutely love it. Now, I haven't been as active this year because the trainings are normally on Mondays and I'm normally on call on a Monday. But I play for, oh God, I don't know, should I say this? Because I'm a Mayo Colleen in a Scrone Kilglass, which is just across the border in County Sligo. I know.
Okay, maybe we'll edit that bit out.
But it's lovely, it's great. It's good old crack and good old fun. And actually, we're going to New York in October to play in a blitz over there. We got chosen to play for a blitz, so I'm going to New York in a Scrone and Kilglass and there's 40 teams in total from between Ireland, UK and actually the US as well, that's all congregating together. And now when we say play, it's 10 minutes aside. There's no scores counted, really. It's great crack and great fun. You'd stand there, you'd be marking somebody, and this person could be in their 50s. It's the first time ever playing, but it's actually a real social aspect.
Oh, yeah. Fab.
When you play, it's very rare that you're playing. You're not allowed to be a county player playing it. You're not allowed to be like, this absolute gung-ho one. There's certain teams that I know that if they're in the blitz, I'm like, I don't know, do I want to play? They're really fierce competitive. They'd absolutely clatter you down with the ball. And I'm like, I like my ankles. I want to keep them. Thanks very much. So it was the rest of it's just about, it's just so much fun. It's a lovely environment. Everybody's just so happy to be there and play a little bit of football. And that's it. And we don't count scores, but Jesus, if you get a goal, you'll have a few shots that night.
Okay, brilliant. I wanted to ask you about your little squeamishes, because obviously you see lots of blood, you see lots of trauma, you see lots of in your day-to-day.
Yeah.
But there's something that you hate. What is it?
Oh my God, it's a wiggly tooth. But a natural wiggly tooth. I honestly don't mind if somebody was punched in the face, their teeth is falling out in front of me and I'd hold it. I just hate when you have the child with the tooth and they're holding it at a right angle to you to show you how loose it is.
With their tongue.
And they're playing with it. It just, oh my God, it just makes my skin crawl with it.
Really?
It does. And
do you ever pop it out for them?
Not at all, no.
Do you not?
God,
oh my goodness,
Jesus,
I
Mary
do
Joseph, no way.
you know what I do? I get I love all this. I get a thread, like a sewing thread, and I wrap it around it and I just pop it out. And they literally, one of the dads once had 4 wiggly teeth at the same time. And I remember getting up in the bathroom and I just got the thread right and went pop, 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 pop. Literally like someone would do thread into the eyebrows.
Oh my gosh.
And they popped everywhere. They flew all over the bathroom. We were
oh my God, that'd actually be my worst nightmare now to see that.
That's so funny. Whereas me now with blood, I'd be a little bit squeamish.
No, I'm like, do you know what I love is a good head wound. That sounds awful, but you get a good one to be able to stop it bleeding, put it back together again, like patch back. I love it. I do love doing that sort of stuff.
Perverted.
Yeah, or dislocations. I love dislocations, putting them back in. And do you know what I love the most is that when you'd have like a rug or bugger that'd be like, you won't get it back in. You're like,
try me.
I will. And it's all about technique. It doesn't matter about like how strong you are, and you just get it back in, and you're like.
Do you like a good abscess drain?
I do.
I love watching them on.
Yeah, the Dr. Pimple Popper thing, is it? Yeah,
but I love it when she sticks it in and you can see the pus just drain out.
I do like that. Yeah, it's satisfying.
Yeah.
Or do you know what's really satisfying? This sounds absolutely awful now, actually, what I'm going to say, but is actually putting in a catheter into somebody who's in urinary retention. So if you have, now we normally do male catheters, when you have somebody that's in urinary retention, because it gives them it's immediate relief for them. And it's actually the satisfaction that you've literally helped somebody in a very dire, distressful situation, that you're able to have provided a skill set, and then just like they're all chilled out. And then you go, right, how did they get into that urinary catheter? How did they get into the urinary retention? So there's little, but no, not the teeth thing.
What about bowel impactions? Do you ever remove them manually?
I did, yeah, twice. I remember ever. Normally that's a surgical job. And you know what? God love them. I feel they're so mortifyingly embarrassed about it. And one of the people that I did was a lady who had been breastfeeding, and she was so taken with the breastfeeding that she'd actually forgotten to kind of really hydrate herself, because you need to consider, and that's how she was impacted. And she had a bit of pain relief with codeine in it that had also contributed to it as well. And yeah, oh my God, I felt so sorry for her. I actually ketamine sedated her and actually helped her with that and took it out, because...
How did you do that? You put your hand up their bum?
Yeah, well, like normally with those impactions, I wonder, do you need like a warning, like don't be eaten when you're listening to this or something? With the impactions,
I think people know what they're going to get with my podcast. It's, literally the conversation could go anywhere.
We're talking about religion and Catholic and bowel impactions.
But isn't it all under the one umbrella of humanity?
Absolutely.
And what happens is so.
Absolutely. And dignity. Like, I remember just with this lady, just thinking, she does not need to remember this, and she does not need to remember that there are people in the room and that she's in a very exposed. So I remember just getting everything ready, sedated her. And normally with the bowel impactions, they would normally have like a hardened piece of stool that would be at kind of the entrance, if you get me. And once you kind of release that aspect, it might take a few goes. Normally then it would be okay to come out afterwards. But I remember she described it as she felt like a wine bottle was in her, basically, and she was not joking. But like, I don't mind. I honestly don't mind. This is, to me, this is an intervention that needs to happen for a patient, and it needs to be done, not threading a tooth out. that could just go out on its own. Do you know what? I don't mind this. This is actually how far it goes. People swallowing dentures.
Oh.
Yeah, I don't mind that. And this is something that you read about in the books. And I remember going, sure, nobody could swallow their denture. Like, it's huge. How do you swallow a denture? And you would always be taught about it, especially if somebody's unresponsive, you take out their dentures in case they all go quite floppy in their airway and it slips back. Or if you're getting ready to intubate a patient, make sure that they don't have a denture taken out. But I remember 2 patients in 1 week coming in, and the first person was saying that they think that they swallowed their dentures. They didn't know, like, and I'm going, how do you not know that you don't have? The x-ray was hilarious. Like, you literally see a set of teeth, hair like.
And she's pointing to the top of her chest.
Yeah, like literally. And then another person came.
How do they not choke? How do they get it into their esophagus?
I don't know. This is my question. Like, how do you think? Did you not have a cough? Did you not have a moment where you were like that? And no, absolutely.
Maybe they're eating, and they just slips back and they don't notice. But one would think that the dentures are too big to fit in there.
I would have thought that there's a plate or something like that they don't, or whatever.
So it gets caught in their windpipe, in their food pipe, rather than go down and them having to pull it out.
Yeah.
Okay.
So but even at that, I'm like, if you had it lodged here, surely you'd feel it as a pressure or something like that. And then the second person that came in that week, I remember twice in a week, and I've never seen it before and I've never seen it since. And the second person was like, I have swallowed my dentures, it is stuck in my chest. And I was like, okay, thanks very much for that. And I remember going, no freaking way could this happen again. X-ray, lovely set of dentures there.
How do you remove it?
So it needs to go OGD, so they need to go down, right down to get it. So that's the scope.
To us mere mortals what OGD is.
Scope, where you go down with a little, like...
pliers or scissors.
I'm sure
pincers
to go down and get it, but that will be the general surgeons would normally do that, so they have to sedate them and basically go down and do it, and then out you go, and don't swallow your dentures again.
And do people come into you ever, and I'm asking this because I know the answer to it because I have other ED nurses and doctor friends. Do people ever, you're like, what is she going to ask? Do people ever come in with unusual things shoved up their backside?
All the time.
And do they say they slipped in the shower?
Yes.
So what are the weirdest things?
Oh God. Lynx Africa can gets it going. Deodorant cans would probably be a very common one. I remember having one before, and this person who came to the emergency department had didn't know where their deodorant can was, and feel that they had relations the night before and feel that they might have used it, but they weren't sure. And I'm going, how do you not know? Just like the dentures in your chest, how do you not know that there's a deodorant can potentially in you? There wasn't, and she was relieved. But I'm like, don't play with deodorant cans again? I don't know. Like,
is it not dangerous putting a can up there?
Yes, especially if the lid is on. Please take off the lid, because I do remember a case previously where the lid remained, the can came out, the lid remained and perforated the rectum, and the person ended up with the lid colostomy.
I would have thought though the pressurised can would be dangerous in case it burst, but maybe that's just
Probably
me.
would if you would. I'd say maybe up on a plate or something like that with it. I mean, how are you going to pressurise a can in a rectum? I don't know. I'm sure there's a science to it.
Okay.
But the can, or the lid, was sharp edges catching it and actually perforating.
Oh, goodness.
So yeah.
Okay.
But I don't, I mean, yes, we see it, but, we always treat everybody with absolute dignity about
Absolutely.
it. And, they get their intervention and then off they go with it.
And there's no need for them to be embarrassed.
Absolutely not. No, we see anything and everything about it. Even I remember having a person that came in post seizure with, oh God, what was the term? And I remember having to look it up, but then I was like, God, fright, because I looked it up on a HSC computer. Was erotica asphyxiation or asphyxia erotica or something like that? What's the term? And I remember just going, oh shit, can I clear the browser on this now? Because, they had a seizure post that where the oxygen levels go down. But you see anything and everything. I love listening to the stories. The kiddies are the best stories. Like they just have good old crack, and
no filter. They tell you everything that mommy and daddy are doing wrong.
Absolutely, yeah. And
probably with a little bit of exaggeration too.
Yeah, exactly. A little bit of sprinkles on top of it as well. Trampolines are big things for the boys and girls, like falling off them. But normally what you find with them is that the girls have probably tried to do like a back double somersault, trying to land perfectly. The boys just fall going up onto the fucking trampoline. Like they don't, or daddy is on the trampoline with them, even though they're not meant to be on the trampoline. And then the daddy falls on the child and breaks their leg, etc. So there's, you just think the randomness of some of the stories that comes in with them.
My boys used to play a game that they aptly named themselves called Feck Arse on the trampoline.
What is that?
So I think that they'd gone through a phase of watching a bit of Father Ted anyway, and obviously Father Jack says feck and arse all the time, so they decided they jump on the trampoline, they bring all their balls onto the trampoline with them, because and being three lads they always have loads of balls, and they throw the balls at each other's head, and they had to jump up and down and avoid the ball being thrown on their heads. And then there was another game on the trampoline called Slap, where they'd strip off their t-shirts and just slap each other and try and avoid the slaps, but they'd literally come out and they would be red raw from the hand slapping. And the giggling and the laugh, but boys are different to girls. They had a net to contain them.
So at least that.
But eventually we had to get rid of the trampoline because, well, my poor dad used to have a heart attack every time. Get rid of that trampoline. There's going to be an accident. We had to get rid of it one time. There was a hurricane, Ophelia or something. Wasn't there a hurricane? Once that blew over a deck chair. But anyway, our trampoline nearly went into the neighbour's garden.
Ooh.
So we
caused a bit of damage.
We had to get rid
so
of it.
was it actually? So you got rid of it before you actually ended up having to go to the emergency department with it?
Yeah, we didn't. I've ended up in the emergency department with the lads on a couple of occasions, but that's just lads and splitting their heads open and all that. And now I get to the stage where I just glue it back myself.
I'm the exact same as well. But I did have to bring Kuon, the second fella, to the emergency department. And I was mortified over it. I was like, Jesus Christ. So he was 5 at the time. Bernard was just got out to the gym. And I remember I was just back from the UK and he had looked after the kids for nearly 4 or 5 months on their own because I couldn't get back from the UK because of COVID and all the crack. And I just remember going, how the hell did he manage this when literally all hell broke loose in the house? So I was up in the bathroom. Fela was on the toilet making a big poo. She was being potty trained. She was happy out with herself. Cahill, the eldest fella, comes around the corner and I think Kuon is going to die. And he was like bawling. I was like, what melodramatics? The next thing, Kuon comes around the corner of the stairs choking with the universal sign like literally blue. And I was like, fuck. So I ran straight down to him and I was like, did you swallow something? And he just nods his head like. So I horse him up the stairs, like carry him up and bend him over the bath, like Heimlich and, stapping the back and all that sort of stuff. While Fela was still on the toilet going, I made a big poo. And I remember just going,
this is so strange.
How did this just go from that to 10 seconds? Cahill bawling his eyes out, praying that Kuon wasn't going to die. And anyways, nothing came out, but he settled down and I was like, did you swallow something? And it was a €2 coin he was flicking. They were meant to be in bed, by the way, at this stage. So he's flicking a €2 coin that Bernard had given to him for his good reading. And I was like, I'll catch Bernard later. And he was lying down and the coin went into his mouth. So I was like, right. So either you've swallowed the coin now and you're 5, and a €2 coin to go through the bowel of a 5-year-old to go between the sphincter of the small bowel and the big bowel. So to pass through there, it's quite a tight. If it was €1, I wouldn't care. But €2 is quite big to go through for a 5-year-old. So I was like, sugar. I'm like, it could cause an obstruction. We need to see where it is. I'm very much like, if he ate a 1 cent, 2 cent, I'm like, good luck, and don't go sifting through your poo to get it. So I had to bring him up the following day anyways. And so I brought him up the following day to the emergency department. I was like, don't look at anybody. Just get up there on the x-ray. Don't say anything to anybody. So I sat at the back then and the x-ray was done and there was no €2 coin, but there was 3 stones. And I was like, go on.
Where
in his bowel. And I was like, was it a €2 coin or stones that you ate? And he's there lying. So he's lying on the table because I told him to smile for the for the photograph. So he's smiling away there. He goes, I said, where's the stones coming from? He goes, oh, Jimmy asked me last week to eat the stones. And he's there still smiling. I was like, get off the table now. I was like,
boys,
you've got stones in your tummy. No €2 coin. And he's like, how are they going to come? And I was like, I come out. I was like, I don't know. And I don't care. You will poo them out. And then we just call him Stony Bum every now and again. And I Bernard and myself are like, yeah, he'll shit a brick.
Literally.
Shit a brick. So there was no €2 coin. It was actually at the side of the bed. So if I had actually looked at the bedside, I would have actually found the €2 coin.
But then you wouldn't have known about the stones. And you wouldn't have been able to call them Stony Bums.
Stony Bum, like, seriously. And
never
what am I going to do?
down.
How am I going to get them out? It will come out in your poo, and you do not look through your poo to get it.
And
so
did he see them at all?
No.
Could be there. They could still be there.
Could still be there, and let's call them Tommy, Timmy, and Jimmy or something like that. No, because they're not going to have any impact really. They were tiny little pebbles of it, and I was like, just don't be pushing things into your mouth that Timmy and Jimmy told you to do. Stop it. I know. I think that was probably the only time that I've had to bring them to the hospital. I've definitely glued them as well, like, and I didn't know. Poor Carl had to come. He broke his ankle. And I remember bringing him down to x-ray and he was on crutches. And I got stopped talking to one of the porters and Carl just crumpled in a little mess beside him because he couldn't work the crutches. And the porter was like, is that your child? I was like, oh yeah, sorry.
I have to go.
Pick him back up again. Like, yeah. So anyways, yeah, so it's all fun and games with them.
I know, isn't it? Okay, Lisa, what bit of advice would you give young people today?
You do you. Just keep going. Short-term sacrifice for the long-term gain, like I said with that surgeon earlier on. If you put in that effort, you will get it out tenfold. And I think the hard work that you put in, it needs to happen. We need to have a generation that actually do a bit of graft and do a bit of hard work, and you will get the rewards.
And what is the meaning of life?
I don't know. Like, I mean, I've struggled with this question. Okay, I feel that we all have a purpose in life. I can't remember the Japanese term. Is it aikigi or something like that? So the meaning of life, I feel, is that we have a purpose and know what your purpose is. And if it's a purpose that you want to feel good doing bushes that, go into a lovely art form, that's your meaning of life. If it's that you want to feel good gardening and you want to make a career out of the gardening, whatever it is that makes you feel good is your meaning of life. So find your meaning of life, find that aikigi. I have to look up that word and see if I'm pronouncing it wrong. It's Japanese. And that's what it is. We're all here for a purpose, but everybody's purpose is different.
And what's your purpose, do you think?
Our Lord's the sick and our Lord's the poor, just to help. And I love it. I absolutely love just helping people in general. So that's it.
Dr. Lisa Cunningham, what a pleasure it was to have you.
Thank you
so
very much.